Welcome everybody to Epilepsy South Africa webinar on epilepsy and lived experiences. Today I'm joined with three wonderful panelists. Just by way of introduction, I'm Charlene Castle, National Director of Epilepsy South Africa. Epilepsy South Africa has been going and been in South Africa since 1967. We're nearly 60 years old. We have been serving people with epilepsy and other neurological disorders and disabilities all these decades. And we've got 6 branches in 6 of the 9 provinces. We've got residential care facilities, psychosocial facilities, and many other services that we really are proud to run across the country. Today is about lived experiences. And with me, I have 3 amazing panelists joining me for this important topic. And the first person is, I don't know where she's on your screen, but Dr. Pintile Machana. She is acting head of pediatric neurology at Chris Hani Baragwanath Academic Hospital. She obtained a medical degree from UCT, pediatric from Red Cross Children's Home, which falls under UCT, before moving to Johannesburg in 2017 to work as a pediatrician, and then she started pediatric training neurology in 2018. That puts Pintile in a very small amount of pediatric neurologists in South Africa and in Africa. So we really are privileged to have her with us. And so all of you know, waiting list to speak to pediatric neurologists is between about 3 to 6 months. So really pleased to have you with us. Welcome, and thank you for giving us your time today. We have Solly Makata, who I am thrilled to introduce. Solly is Epilepsy South Africa branch director from our Free State and Northwest branch. Solly has been with the organization for more than 2 decades, and his insight into the community, his experience into community experiences, brings such valuable perspective to South Africa today in the context of epilepsy. Our third panelist is Justin Decker. Justin has been involved with Epilepsy South Africa since a child. I think he's had epilepsy since he was a child. Justin is now a resident in the rural area of Dundee in KZN. And one of the things when I speak to Justin that he always mentions is his active and love for BMX bike riding. Jason has completed in South Africa and international levels and been in 3 international world championships. So in addition to that, Justin serves on our national board as our youth representative, and it's just wonderful to have all 3 of you with us today. And I certainly look forward to hearing you weigh in on this really important topic. We know we truly understand a neurological disorder when you hear from people themselves that live and experience it, but even as important as that, listening to the support team around that person, from your medical practitioners to your social development teams, to your carers, your family, and your friends. So without further ado, I'm going to jump in, and I'm going to start by asking really Pintile, and we're going to ask Pintile for some of her insights. And just remember, today is linked to March in South Africa, which is Human Rights Month. And this is when we couple the lived experiences with the rights of a person with epilepsy in South Africa and what you can ask for and expect, and giving you that voice. So without further ado, I'm going to ask Pintile to please just share with us what is epilepsy, the different types of seizures, the diagnosis, some of the what it is, what it isn't, the myths. We deal with so much of that, and often the stigma is far heavier for a person with epilepsy to live with and to deal with than actually epilepsy is itself. So, Pindi, thank you so much for being with us today once again. And can you all see my screen? So I'm going to ask Pintile to unmute herself, and I'm going to hand over to her. Thank you, Pindi.
Thank you so much, Charlene, for that wonderful presentation. And so, yeah, I'm going to talk about just epilepsy, just Oh, we can move the slides. I forgot I'm not in control. So these are the questions that have been given, and what epilepsy is, what the epidemiology is, seizure types, causes of epilepsy, diagnosis, and treatment. Next slide. So by definition, a seizure, it's a transient occurrence of symptoms and signs due to abnormal, excessive, or synchronous neuronal activities in the brain. And just because the patient has a seizure, it doesn't mean that they have epilepsy, because there are other number of conditions which can be associated with paroxysmal events, which can mimic a seizure or epilepsy. So when we define epilepsy, you'll see on the subsequent slides what criteria needs to be followed. Next slide. So this is the criteria that needs to be followed to diagnose epilepsy in someone with seizures. You need to have at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure, and the probability of further seizures similar to the general reoccurrence risk. So basically, we're talking about a patient that presents the first time with seizure, and they have abnormal brain, or maybe there's a history of hypoxic ischemic encephalopathy. So we know that those patients are actually at risk of having subsequent seizures. And of course, if you're diagnosing one of the epileptic syndromes, you don't have to wait for the second seizure. You can just make the diagnosis and start treatment straight away. Next slide. Charlene.
Sorry, something's frozen on my side. There we are.
So looking at the seizure types, this is something that the clinicians sometimes get it wrong when they speak to us neurologists. Every seizure is called generalized tonic-clonic seizure, and that's not true. So you have to classify, when you classify them, you look at the time of onset. When the seizure begins, what happens? Is it focal, meaning that it's starting from one side? Is it generalized, that's the whole body? Or we just don't know what the onset is. And with the focal seizures, we have to look at whether there is awareness or they have impaired awareness. So, and then again, some of the focal seizures can have involvement of the bilateral networks. In the past, we used to call it focal seizures with the progression to generalized seizure. And then the motor seizures, so you can have, this is a tonic-clonic that they always refer to. And then so you get the tonic phase and then the clonic phase, and this is basically the clonic phase, and then you can get tonic seizures, you can get myoclonic jerks, sometimes myoclonic, tonic, and clonic seizures, and then you can get myoclonic and atonic drops, or atonic drops, and sometimes epileptic spasms. And then there's what we call absence seizures, which looks like daydreaming. So those are the patients who just stare into space and they are actually having seizures. And then the last group, we actually don't know what the onset is. And most of the time, these are the ones that we just see them mid-seizure. Next slide. So in terms of diagnosis, we have to get in a detailed history from the patient. So you need to know what they were doing before the seizure, during the seizure, what happened, and then what happened after the seizure. So if some of the kids can actually tell when the seizure is coming, so just find out if there's anything, are they feeling some stomach upset or nausea? Some of them feel scared. You need to know all of that. And it's also important to get history from the caregiver. Ask them to act it out because the descriptions are usually terrible. So if they act it out, they actually sit on the chair and they will show you that there's going to be tonic posturing and then the patient is shaking. And if the seizure is happening at a school, you can ask the teachers to be involved as well and just describe it to you. And we always encourage videos. I know it's actually, it's not easy for a parent to see their child seizing, but if we can get videos, they're usually very helpful. And if the diagnosis, if you're uncertain, you can always defer or ask for help. And investigations, they actually don't really help that much. Next slide. So these are the myths that people have about epilepsy, that EEG can be differentiated between epilepsy and mimics. The truth is that seizures and epilepsy a clinical diagnosis, and normal EEG does not exclude epilepsy. The other myth is that abnormal EEG confirms epilepsy. And the fact is that it only supports the diagnosis of epilepsy. And you must remember that EEG is not a confirmatory test. The other myth is that the follow-up EEG are useful to monitor treatment, and we actually get that a lot in medical legal cases when we have to follow these patients up. The fact is that the EEGs are not routinely done, except for patients with epilepsy syndromes like West syndrome. So you need to know if the treatment is effective or not, or one of the epileptic encephalopathies or childhood absence. And the other disadvantage about routine EEG is that some of the benign focal epilepsies, when the patients reach remission, when you repeat the EEG, it might still remain abnormal for quite some time. So it doesn't help with your treatment and decision making. Next slide. So there are things that can mimic seizures, like cardiac events. What we recommend is that when you have to investigate, rather do an ECG, because the patient's going to die for an arrhythmia, okay, not for a seizure. If you miss a cardiac event, they're going to die. These are the indications for EEG. Of course, you have to support your clinical diagnosis, and you have to classify your seizures into generalized or focal epilepsy, also to look at the other epilepsy syndromes like West syndrome. So these are the electroclinical syndromes whereby we look at the seizure type, and then to confirm the diagnosis, you can look at the EEG type, also to prognosticate and just check the recurrent risk. And the list is actually quite long, and some of the bottom ones are actually not that urgent. They can wait. Next slide. So we're just going to jump into treatment, because I don't have much time. So you just have to remember that it's individualized treatment. So it's not that one shoe fits all. You need to get the precise diagnosis. Treatment must be precise. The advice is that start with one agent at a low dose and start to build up slowly and ensure compliance. And remember, we don't advocate for therapeutic trial of anti-seizure medication, because remember, benzodiazepines will stop any treatment. So you might think that, oh, the patient probably had epilepsy because they stopped seizing. Or the other thing is that, like, some of the paroxysmal kinesiogenic disorders, they actually respond to carbamazepine, which is one of the anti-seizure treatment. So you need to get the diagnosis first. And then there is a list of anti-seizure drugs that we have, and there are other indications. I'm not sure what's happening, Charlene. Sorry.
Sorry, doctor.
Okay, and yeah, on my right, there's just a list of anti-seizure medication that we have available. Oh, yeah, we actually don't have all of them available in South Africa. Next slide. So the message for today is that epilepsy is a clinical diagnosis. Remember to do an ECG, and you may need an MRI. Epilepsy treatment is tailor-made, and treat the patient, not the EEG. Remember, time is brain, so especially for epilepsy syndromes, just refer them sooner. If you have any doubts, you can always contact us. Thank you so much.
Thank you so much, Pandile. I think everybody really has gauged and learned by what you said. And we often assume in our environment where we are working with epilepsy, and I know it's one of your focal areas in your practice and one of your passions, is that we assume people know this information where it's actually not common knowledge, and it's something that we always need to be talking about, right?
Yeah.
And I don't think when you do a consultation that often you have enough time in your consultation to actually be sharing all this information. So what we often we encourage and we recommend is that if somebody has developed epilepsy in your circles, they're going to go and see a doctor, is actually read online, get yourself information and educate yourself a little bit. So when you go to see your neurologist, you can actually ask informed questions that you want and that you need information to. So I'd like to, off what you're saying, Pandile, I'm going to we'll get back to the end just for our participants, is that we'll have a question and answer session at the end. I think it's just easier. Is Justin, you've heard Pandile really talk about the clinical aspect of epilepsy. Now, as a person with epilepsy, I'd like for you to tap into what she's saying around your experiences living with having epilepsy through your life, your exposure and experience with seeing specialists, and really epilepsy as a teenager, as growing up, and highlights of things that have stood out to you as what challenges epilepsy has caused for you and that you've faced. So, Jason, I've given you a whole framework and there's a whole lot of information, but over to you, and look forward to hearing your story.
Thank you, Charlene. So for me, I've had epilepsy twice in my life. I've had 9 years in between where I was cleared. So from 9 months old to 5 years old, I had febrile epilepsy. Because I was so young, I don't remember too much on that side of it. But at 14, I got diagnosed with absence epilepsy. And how that all started, I didn't initially think it was epilepsy when it started. I thought it was just exhaustion. So I had been riding my bicycle the entire day, and as I took off on the one jump, I just blacked out. So I didn't initially know what had happened. I thought I was just exhausted. But then the next day in class, it happened twice in the same lesson. And that was when I realized there's a problem here. I need to go see my doctor, my neurologist. I need to know what's actually going on because I haven't blacked out 3 times in 2 days before. I went and I got the EEG and an MRI scan done, and the neurologist said to me, listen, you've got absence epilepsy, you need to be on medication again. Which initially was hurtful to me because I've been cleared for 9 years. I wanted to stay cleared, but I accepted and I asked the doctor, what does this mean for me regarding my sports, for my whole social life and that? And his response to me was quite simple. He said, figure out what your triggers are and sort them out. Get your triggers and your seizures under control, and then continue. When I got those under control, or when I was on the verge of having them fully controlled, I went to the one national championship for sport, and I wasn't there to compete. I was just there to watch because it wasn't under control yet. Luckily for me, my competitors, they came to me and asked me, why aren't you on the starting line with us? We need you up there. There's someone missing in our class. And when I explained to them that I'm out for the season just until I've got my epilepsy under control and then I'll be back, I was lucky enough to have competitors say that were there supporting me that said, get it under control, get back on the line. We need you back on that start. If they had said to me, no, it's too much of a risk to have you there on the start, I know I would have had to stop the sport that I love, the lifestyle that I enjoy living. But because I had the competitors and the friends then that said to me, get it under control. If it starts becoming a problem for us, we'll then let you know. But get back as soon as you can. I'm happy to have had the friends, the family, and the competitors constantly backing me, even if I was down and not thinking that I could go further with this epilepsy with sports or in school, I had the support behind me that could constantly push me forward. School was a little bit on the tricky side because I had to make sure that my stress levels weren't getting too high where I was going to have a seizure while writing exams or stuff like that. That was a hard part for me, especially with the absence epilepsy where my memory cuts out every now and then. I was a little bit nervous in high school with the seizures and with my epilepsy, but I managed to get through it. But I managed to get through it. Yeah, luckily because I've had it twice in my life, I don't remember ever being treated differently because of my epilepsy. Because when I entered high school, or even junior school, my friends and my classmates, they already knew Justin's got a history of epilepsy, make sure that something doesn't happen head-wise, meaning concussions or something like that. So I've never really been treated differently, but that could possibly be because born and raised in a small farm town instead of a big city where not everyone knows you. So I'm grateful for the people and the specialists that have helped me with Epilepsy South Africa backing me constantly, and with my friends and family and competitors from the sport backing me.
Thanks, Justin. Thanks. I think what's coming up for me, Justin, and really what I do know is as a person with epilepsy, I do know how difficult it is to speak about your own epilepsy. And yeah. I only started, funny enough, although I am where I am today, I only started about speaking about my epilepsy 10 years ago. I could never speak openly about it. And it's changed my world in terms of finding my voice, because I have stood in front of various audiences and they've needed to hear my story. And I think as a person with epilepsy, we don't realize the importance of telling your story, however complex or simple or whatever you've said. And I think one of the questions that's come up immediately, and I've really got an important pressing question for Solly, is to ask Pandile, one of the things that Justin has said is that his epilepsy went dormant for a period of time. Can you just share with people how that happens? Because epilepsy is not curable, but I think just put that in context for our guests.
Oh, sorry, Charlene, is that addressed to me? If I understand well, he says he started off with febrile seizures.
Yes.
Yeah, so we see these ones commonly in small children between the age of 6 months and 6 years. So these are the seizure types that the children should outgrow. And then there is a criteria for diagnosing epilepsy, febrile seizures. Okay. And so when we see patients with febrile seizures, we try and counsel them about the risk of recurrence of febrile seizures and the risk for epilepsy. So if they have what we call febrile complex seizures, so if it's longer than 10 minutes, and if it's a focal onset, because the febrile seizures are supposed to be generalized less than 10 minutes, and the cause or the trigger should not be coming from the brain. So if you have meningitis, we can't say it's febrile convulsion. And so if it's prolonged and it's from one side, and the child is of a younger age, sometimes we look at less than 18 months, Then we call it complex febrile seizures. So these are people who are actually at risk of recurrence of febrile seizures. Okay, of course, we look at the family history as well. Mom and dad, if there's a family history of febrile convulsion. And then we look at the risk of developing epilepsy. So if you have febrile seizures and you have underlying neurological problem, you have febrile seizures, let's say your brain, you had hypoxic ischemic encephalopathy. So there is a risk for you to have a febrile convulsion, epilepsy, not febrile convulsion. And if there is a family history of unprovoked seizures, it also puts you at risk of developing epilepsy. So those are things that we look into. And yeah, and then the absence, it sounds like it was just a different seizure after that. I'm not sure if he was part of the epilepsy syndromes, or was it just absence, and it just remained as absence throughout. But yeah.
Yeah, thank you. We'll jump into further conversation with that. But I think overlaying this conversation is something that is really, really important. And Solly is with us, and I really want him to weigh in on this, because we are hearing a lived experience, we're hearing a medical input and information, which is both absolutely amazing. And Solly, you are really, again, seeing a different angle of epilepsy in South Africa. So what is the significance this month of talking to the rights of a person with epilepsy? What are you seeing in terms of what's happening in the communities with rights and with people being marginalized, being stigmatized, having, just a view on that? I'd really like to hear. You spend a lot of your time through nearly 30 years of service, and thank you. I think you're a walking angel. So over to you, Solly. You do need to unmute. Solly, you need to unmute yourself.
Yeah, sorry about that. Human Rights Day holds a very significant meaning for persons with epilepsy, as it highlights the fundamental rights and dignity that should be afforded to every individual, regardless of their health condition. And we have realized that because of the neurological nature and which is characterized by recurrent seizures, often persons with epilepsy are faced with various challenges. And these challenges are such like stigma, discrimination, limited opportunities and barriers to health care. So as we enter Human Rights Day, we underscore that these challenges need to be confronted. Specifically, we focus on issues like access to health care, which is a major challenge for persons living with epilepsy, due to the fact that the sophistication of the treatment methods that are available. People in the outlying areas, in the rural areas, have a difficulty in accessing real adequate services to help them to be able to have a degree of well-being and be able to function in society. As it has been said here that with support of the community, particularly access to treatment, people can be able to manage the condition and live effective and contribute to society. Another significant issue is the issue of education, because especially the child epilepsy seizures that happen at a very early age, there is in society, the effort to keep people from education, and by virtue of that, not allowing them to fulfill, their potential to actually be contributors in society. If you hear stories of individuals that, had a child with epilepsy, you will find that the major challenge is the fact that they have been prevented from education, and that connected with the issue of lack of access to medical health care and services. It makes it very difficult for people to be able to actually continue and function in society. Employment is another problem that subsequently because of epilepsy and the stigmas and the attitudes of society, people with epilepsy are also prevented from actually getting gainful employment, although they can contribute. The understanding is that there should be reasonable accommodation, which is emphasized in the the statutes around human rights, that there must be reasonable accommodation to understand that a person with epilepsy doesn't mean that they cannot be employed. Also, social inclusion. Social inclusion means that people are combated from participating in daily activities. The example of the cycling, where you find that people say, "Oh no, you can't do this or that," but we can see how, with the spirit, with the support, we can be able to do that. And obviously, legal rights, because people with epilepsy are assumed to be inferior, and therefore we are not given their rights and are discriminated against. So overall, the issue here is the fact that as we enter Human Rights Day, we need to realize and espouse in clear terms the whole issue of enunciating the rights of persons with epilepsy and being active in encouraging that treatment and support by society can contribute to a better life for people with epilepsy, and they can also contribute, economically and in all facets of life to be normal individuals. And Human Rights Day emphasizes this, and we hope that, as we undertake this, where we create awareness, we share experiences, lived experience, we can be in a position to give people with epilepsy a better life.
Thank you, Solly. I think you've touched on so many different topics there, and I think each of the topics would really trigger so much more conversation. I know already in my head I'm thinking, okay, well, we can discuss this, we can discuss that, but where I want to share with you, and I think something that really stood out for me is that the point of sport, and we know Justin has been very active in his riding and his BMX career, is, people have always said specifically to me, was like, the fear of me doing sport and hurting myself. But yeah, I've been in real serious predicaments where that was a possibility, but I also had parents who would acknowledge that I could be hurt whether I had epilepsy or not. And there was a compounded complexity, a compounded concern, but it didn't stop me being put on a pony, and put on a safe pony, that when the pony trotted or galloped and I was having a seizure, I was safe, and they would wait for me to come out. They knew the pony would slow down. When I was playing netball, I mean, all of us South African girls, it's our favorite sport, right? Every single one of us. And I would catch the ball and I would have an absent seizure, walk off the court with the ref blowing furiously, and because now you're not allowed to walk with the ball, right? And my mom would pinch me on the side of the field. I'm not saying everybody should pinch people with having an absent seizure, but it was what my mom used to do to me, and it used to stop. So I'd have an absent seizure. I used to turn around and be pushed back on and sent back, like just redirected. And I think it was that normalizing of my epilepsy, and encouraging me. And anybody who knows me will know that I'll say to you, the most pivotal, most impactful moment of my life was when I had my first, we used to call them grand mal seizures, as Pandile will remember, I'm sure, but was that first one when I was 8 years old. And my parents were asked by the school to put me in a special needs school because my cognitive ability was so jeopardized. And my parents sat back and they said, no, Charlene will be given every opportunity and all the support we can possibly give her to give her a normal life where she can have the opportunities of anybody else with a brain that doesn't have epilepsy. And that moment of belief in me has really defined my life. And I've never known the word I can't. And it's almost to my detriment sometimes, because I push and I push and I push. And I always say my epilepsy is my warrior, because it'll stop me when I start feeling, I'm about to have a seizure. But one of the things, Solly, you also mentioned was about stigma and acceptance and rights. And we recently did an Indaba at Netcare, and it was really something that came out. Really, it's kind of an aha movement, is that moment we're all quick to say, society must break the stigma, society must break the myth, society must learn about the this isn't a possession, a spirit possession when you have a seizure. This isn't a need for exorcism. I'm not contagious as a person with epilepsy. But what stood out for me was the self-stigmatization. And often with epilepsy, you do self-stigmatize, and you do say, well, I can't do that because I have epilepsy, and I'm stupid, and I'm not going to attempt that. And you kind of put all these things on yourself. And we all know in life we've got to do self-development, we've got to do self-awareness and self-work. And with epilepsy, those internal voices are so dangerous. So yeah, just a little bit around the stigma point you made. I want to go ask to, we've touched on stigma, Solly, and I want to jump into the culture that contributes to the stigma surrounding, but I just want to jump into Pandile going, because you've mentioned again the rights with healthcare system and how the healthcare needs to address the individual needs with people with epilepsy. And just, Pandile, how can this change to ensure that people with epilepsy are protected? What needs to change in your opinion? And is there something that, as a person with epilepsy, I can influence? How can private healthcare come into the conversation? You're in a state hospital. How does that come in? So maybe just deep dive that, because that's always something that I hear. I can't get access to my medication. I can't get access to a neurologist. I can't get access. So yeah, can I just leave that to you? I think that's a really important question to throw you in on, and it's quite a controversial one, I know. So
yeah, it is a controversial one, Charlene.
I do have an abundance of questions coming through, but again, we'll handle them at the end.
So Solly touched on access to healthcare, which is a big thing. There aren't many neurologists in the country, but remember, epilepsy is something that can be managed by pediatricians as well. So the challenge comes when we have to prescribe medication. Sometimes it runs out, and then we don't know how long it's going to take. But then there are forms that we have to fill in and send to pharmacy to motivate for drugs that are not available as well. So I'd really encourage doctors that are listening that it's a very long, and you need to do a research, and sometimes you attach articles. So let's do that and just advocate for these patients to get the correct treatment. And you touched on the schooling that they wanted to put to the special school. So we're forever writing letters to the teachers, because they're part of the team as well. We want to work together with them. If they think that you're struggling in school, we have to check, is it because your epilepsy is not well controlled, or is it because there are other comorbid conditions that we need to treat? Before they think about sending you to a special school, those are things that need to be addressed. And then there has to be an educational psychologist involved as well to do the assessment. Like, does this child need to go to a special school, or can we send him to a remedial school? You know, once they start to do better, then they go back to mainstream and things like that. So there are so many options when it comes to that. We also need to educate the teachers about epilepsy in general, because remember, they need to know what to do when the child is having seizure, and they need to know that not all seizures are just generalized, the shaking of the body. You know, like Justin, they need to know what an absence is. You're not daydreaming, you're not being naughty, you're not sleeping in class. Okay, I mean, it's brief, but then you come back. And when it comes to the stigma that Solly also touched on in terms of education, kids are mean. Kids are mean in school. They're mean because they don't know. So you realize
Yeah.
that if you tell them what's going on, they'll actually be very supportive. Okay, so they'll support their friend, whether it's on the soccer field or whatever that they're doing during the lunch break and things like that. So it goes back to education and making sure that there's access to health, working together as a team, and they can have psychiatric problems as well. So that's when we involve the psychiatrist and psychologist and everyone else to be part of the team.
Thank you, and Justin, would you like to just
Yeah, I just want to.
say anything about what's being said, because there's a load of information going here.
Yeah, there is. I just want to go back to what Pandile said regarding with the friends at school judging you for the stigma that's actually behind it, not because of what the seizure is. When I've got people that come to me and ask me questions regarding epilepsy, or when I'm doing a talk, I try to get the people at the talk that I'm doing, I try to say to them, I'm going to ask a question, and it's a tricky one for a lot of people to answer, but there's a reason why I ask it. And I ask the audience, who has epilepsy? And then I go on and say, the reason why I'm asking this is not to get you bullied or anything like that. It's so the people around you, your friends, your classmates, your colleagues, everyone that you're dealing with, then know, okay, you've got epilepsy. This is what needs to be done if you have a seizure. They know how to help you in the case of having a seizure.
Yeah, thanks, Justin. I think that those are really, really important. And I think just maybe jumping around a bit, but to share something, and I thought sure Pandile's mind's going to go when I say this, but from an educational perspective, I mean, I was in my prelim exams and matric, and we know everyone says that's something that, you know, it influences your future. And I thought I'd done really well. I studied hard, and my parents, I'd come home and go, no, I did really well. And when results came, the principal called my parents in and said to me, how do you think you did? And I remember I was nearly 18, and I gave them feedback, and he started bringing out my papers, and most of them were blank. And because of the stress, I actually had a certain type of seizure right through every single exam. So it was very, very traumatic. And when I got my final matric results, I found my parents sitting there sobbing their eyes out. In those days, it was newspaper for Justin. I'm not sure you'll remember the newspaper matric results, but they were crying. And not only had I passed matric, but I'd got a university degree entrance. So I think stress, I mean, we will have another webinar on the stress, on nutrition. I think we're jumping into this lifestyle in the next webinar. But I'm going to just ask Solly. Solly, where's epilepsy? I mean, just talk a bit about the support systems that you know to be in place in community-based support systems, in any specific. What are the support systems that are in place, and how without them do they affect people? You're on mute, Solly.
Sorry about that. Yeah, I think the critical thing, as we have emphasized the issue of support, is the fact that, you know, services of Epilepsy South Africa in different, you know, formats. One is that we provide residential care. Within the residential care, we provide an environment where people are, you know, given access to medication, and their medication is actually administered in a proper manner to ensure that, you know, they are having their seizures controlled. And because the environment is actually a conducive environment, they can live fulfilled lives, because we engage them in activities of daily living to ensure that they have a quality life to be able to, you know, prosper. It is just unfortunate that the residential care facilities that we provide are provided at a stage where people have reached, you know, stages of no return because of the age, because of that, and they are more in a care environment. But we also do outreach programs into the communities where we are in the clinics to provide information and support to people that have been diagnosed, and also to ensure compliance by running group work sessions with them to be able to deal with, some of the educational aspect of self-care, of, how to use medication, and also just to be able to live in society. Overall, the key thing is that we provide a psychosocial service to ensure that people with epilepsy are able to, live to their highest potential and be able to unleash that so that we can have a quality life. The challenge, is definitely the fact that in the outlying and rural areas, access to services is actually limited because of the vastness of the area and also the vastness of, medical care services. For instance, in the facility that I'm in, to get real neurological services, we've got to travel minimum of 80 kilometers and in some cases about 300 kilometers to Bloemfontein. So with that, it becomes a real challenge to actually give proper attention, to the care and ensure that people are getting adequate treatment. Okay, we can accept that, if your general practitioners and your pediatricians are provided with education, but, in some of the areas, those are also not absent. So it is a challenge. But as an organization, we are modelizing and advocating for improvement of these services to ensure that, people are given the best opportunity. And hence, on this time, when it's a Human Rights Day, it's a Human Rights Month, we are really emphasizing awareness about epilepsy, awareness about services available so that people with epilepsy can actually receive the rights that they are entitled to of access to these facilities.
Thanks, Solly. And I think what's really the messaging today is a lot about what there are support services, and the systems that are around are vital for people living with epilepsy or with epilepsy. What I'm going to do is I'm going to change track a little bit. We've got some very interesting questions coming through, and a lot of them are, as we would expect, quite medical in nature. But I think there's a few people that can actually just reply from an experience. And Pandile, please, what we do know for everybody that is attending, we don't give medical advice. What we say is we'll give you facts about what items are, but please, just be cognizant of that Pandile is not here to do consultations. Okay. So the first one is, what is the cause of and excuse my expression, a hemodialysis patient, the cause of a seizure to a hemodialysis patient?
Yeah. So it's kind of like a difficult one to answer because it's not just one cause. You have to look at the patient as a whole, get the history. Why are they on dialysis? So I'm assuming that they're in chronic renal failure and they might have hypertension as well. So with high blood pressure, there's something that we call posterior reversible, it's called PRES, encephalopathy syndrome. So those patients can present with seizures and visual loss. And then some of the patients on dialysis as well, their blood tends to clot easily. So which might throw a clot into the brain, and then you get a stroke, and then you go into a seizure. And with hemodialysis, it also affects the electrolytes in your body. So remember, we said other seizures are provoked. So if your electrolytes are abnormal, I'm talking about things like sodium and calcium and things like that. So you might present with something that looks like a seizure. So the list is long. Difficult. So you have to look at the patient as an individual.
Yeah, and I think that's a very important message. And I often hear this, and often everybody that I'm engaging with, is that we've got to remember one size does not fit all people with epilepsy. It absolutely cannot. We are unique in our in many, many ways. Another
Yeah.
question that I get faced with, and I'm sure each of you on as a panelist is going to, and is nighttime seizures. We know last year a renowned 702 talk show host had a seizure during his night and passed away. And I think every time someone discusses this with me, I almost start crying, because it really is. I think you've got epilepsy; it's your worst nightmare. But is there any way, or that it may happen? But is there any way, Pandile, of predicting these, of signs that you've had a seizure afterwards, for family to look for outside of the bedwetting, outside of the normal things that one would look for, but really just a quick view on it, because again, it's a huge topic. We had SUDEP month, we have SUDEP month annually, where we really also speak to this in detail. So I think just your view.
Okay. I'm glad you mentioned the term SUDEP, because when you're thinking about, when you talk about nighttime seizure, that's always my concern, the sudden death while they're asleep. So, which makes it important for us when we look at the seizure control in clinic. We always want to know about the nighttime seizures, because those ones we definitely have to control. They're at risk of SUDEP. So some of them can just say, present with urinary incontinence. So you wake up and clothes are wet and you don't know what happened. And some of them are just very sleepy in the morning when they have to go to school, because they don't know that they had a seizure. So my recommendation is always that those kids should not be left alone at night. Okay. So they have to share a room with someone, because some of them are silent seizures, but the ones with the shaking, you can actually feel them shake. And then the tonic ones, sometimes they can make sounds like, then you know that there's something wrong. At least you can go and help them, put them in a comfortable position, and know what to do in terms of emergencies. But patients with nighttime seizures, I always warn the family about the risk of SUDEP. And I know it's a scary thing, and but they need to be aware of that.
I think one of my takeaways from your answer, and thank you, is that if you can, ideally, is someone sleep in the room with you. There isn't, I often get asked, are there devices, seizure alert devices, that a family can have, like a baby monitor, that there are ways to explore that. South Africa doesn't have one specific product that I know of, but they are overseas, and they really are expensive because we bring them in dollars.
Yes.
One of the comments is that consult with a psychologist. It really is, they offer really very valuable information to the family, and again, it's easier access to a psychologist than to a neurologist or a specialist sometimes. So a coach and a counselor really does help. I think one of the questions that came up when Jason was speaking, and was that there's times when someone with epilepsy then doesn't have seizures for large lengths of time. We know people can outgrow epilepsy, like it goes, you do outgrow, there's always this terminology. But do you take it then, Pandile, that then the epilepsy as a diagnosis has disappeared? Or what is your advice to somebody when you've got a teenager that hasn't had seizures for 5 years, or an adult hasn't had seizures and gradually taken off meds? Just give us your view on that.
So that will depend on the seizure type. We've mentioned febrile seizures, that they should disappear by the age of 6 years. You shouldn't be at risk of getting those. And then there are other so-called benign Rolandic epilepsies that are also age dependent. You should outgrow them. So the patient going into remission depends on the seizure type. And then we get to the so-called idiopathic epilepsies. We basically say that because we don't know the cause. So what we do is that if you're seizure-free for 2 consecutive years, so it's not easy for us to tell whether is it because the treatment is working or are you in remission. So the risk that we normally take is to say, let's just start tapering down and eventually stop treatment. Okay, of course, you have to calculate the risk. Okay, you have to see who is at risk of having relapse and who is not. And so some of the patients come back with seizures. and some never come back and they completely outgrow them. So again, it just depends on the seizure type, and yeah, because some of them are age-dependent seizures and some are provoked by other things.
Thanks, Madila. I'm going to just ask Justin, have you ever had auras?
No, I haven't had auras exactly, but I've had similar sensations that's been on the verge of the auras.
So interesting, you know, I never had auras. And let me just quickly explain to everybody what an aura is. It's pre a seizure, you can get multiple different types of warnings. So your tongue can feel funny, you can feel like things are crawling up your arms, you can see sparkly lights, you feel disassociated. And I never had auras till 4 years ago. And when my seizures went really, really rife, and I've had an excessive, I think we've lost count, but an excess of about 60 grand mal or temporal lobe seizures in 4 years now. But the auras are indicative of a seizure coming on. And it makes life, I don't want to say easier for simplifying it, but it does make life easier when you do have an aura, because you've generally got a couple of seconds to say to somebody, hey, not okay, is an aura, I think I'm having a seizure. And you can make yourself safe quite quickly. Be conscious of, if you are feeling funny like that, of asking people around you, have I missed a sentence? Because through my life, and again, it goes lived experience, I'll have friends through my life that go, Charlie, you know, one of the things, you just don't listen. And I'm like, what do you mean I don't listen? Because I'm such an engaged personality. And they'll say, well, we'll be talking and you just like tune out and then come back like you've lost interest in us. And I'll go, well, actually, everybody, I'm having an absence seizure, and I would only know that because you mentioned it to me. So often with epilepsy, you are relying on people's feedback around you to know if you're having absence seizures or not. And, you know, something that I've really had to educate people or myself around is the difference between types of seizures. Because what's the difference of an absence seizure and a temporal seizure? I mean, it's very easy to know. Absence seizure will last 20, 30 seconds. There's aren't convulsions. There isn't. You don't fall down. You're not. It's very different. An absence seizure, you can by sure have a car accident, right? And that's the risk of knowing how controlled your epilepsy is or isn't. I've driven under a truck when I was about 19, as an example, and I'm very grateful no one was hurt. But that's always a risk. And the temporal the big seizures are when you have your body goes stiff, your eyes roll, you can generally, big misnomer is that you put something in somebody's mouth. Don't. It's an old wives' tale. You're going to get bitten, number one, if you put your finger in, it's going to really hurt. But physiologically, when you turn us onto our side, when we're having a big seizure, our tongue will naturally fall to the side, keeping our airway open. So we're then able to breathe, and the risk of asphyxiation really minimizes. Don't panic. Sit, call for someone to help if you're really feeling at risk and panicked. One of the questions, and I think again, Solly or Justin can just come in and here, or Pandila, any of us, is that patients prefer not to share their diagnosis and talk out, right? We all experience what we're talking about it. So one of the things, let me ask Solly, what is the biggest thing that you've encountered that people see as stigma and why they don't talk out?
Yeah, I think the biggest thing is that, for instance, fear of disclosing, in employment, the fact that you experience seizures, because what happens is that you would not be given an opportunity if people regard you to be having epilepsy, and also the reluctance of employers in some cases to be able to do reasonable accommodation to provide for persons with epilepsy. So the major issue is that people tend to do that. I mean, the personal experience is that I was at the restaurant and this waiter suddenly had a seizure. And, the immediate reaction, was to call an ambulance, and the way that was given, his shift was given to somebody else. And I had to intervene around the issue of proper care that you've been explained, on her side and that type of thing. So obviously, when I asked around, did you know that this person, has seizures? The core employees understood that she does have that. And obviously as well, what had happened is that she had been working a long shift. It was at night and she had been on a shift for the whole day, So the stress and everything would have triggered, the seizures.
Absolutely.
And that type of thing. So,
Absolutely.
So definitely, with reasonable accommodation, there would have been, the consideration of that person being able to do that. And then maybe one other experience, in a taxi, the person has a seizure and, suddenly everybody jumped out of the windows and whatever, because he's actually,
Oh, my word.
something else. And obviously the person became incontinent and was chased out of the taxi, So the challenge is society not being able to accommodate, and also the stigma around, possession, that it is spirits that are actually coming out and not wanting to be infected and so on. So it makes it difficult. So people don't disclose, but also it is to their disadvantage, because with that, they cannot get help.
I think, I know Justin said he doesn't have auras, and I make a joke that it's really, I'm so grateful for having auras. But solely like you talking about someone having in a taxi or a public area, when I feel a seizure coming on, I've got about 15 to 20 seconds when I'm having a seizure. And yeah, you can break through your medication. One of the questions, you absolutely can. I know Pandile will weigh in on, but you can break through your medication for a range of reasons. But I've actually been able to say to someone in a public space, okay, I'm going, don't panic. I put my handbag next to me on the floor, put my head, I was like, get me into fetal position, sit with me, hold my back, and let me come back. Don't just, here's an emergency call and I'll give them my phone. So it's absolutely, have I wet myself in public? Yeah, it's horrible. But what I just say to somebody quickly is just throw your coat over me, throw your jacket over me. So again, the more you can educate people around you, and the quicker you are to communicate. And if you don't have auras, make sure you're communicating. You can buy little bracelets. You can go to our website. There are little bracelets, ice tag bracelets that are quite inexpensive, that show that you have epilepsy. And yeah, their Pandile's got one. And they're absolutely superb to communicate instantly. You can just flick it. People recognize them generally. So yeah, what I want to do is it's 9 o'clock and the time just flies. We've got so much to talk about, but just a few points is that we haven't registered this webinar as yet for CPD points. We will register the next ones, quite a valid point. Yes, the recording will be available on our YouTube. It'll also be made available on our epilepsy support page on our Epilepsy South Africa Facebook page. And then there are a lot of other questions that we can't get to. So what I'd like you to do is just take info@epilepsy.org.za. Please knock them off to us and we will get back to you. And my last point is that we're uploading more and more toolkits onto our website under resources with every single day that goes. So please go and download brochures. They're going up in different languages. We really are getting more and more of a team onto that to make more and more relevant information in South Africa available to you. Last comments. Let me ask, last comment from Justin.
Yeah, I'd like to thank you guys for this opportunity to join this webinar. And I've learned a lot that I didn't think about previously. I've learned a lot myself. So I think everyone that joined on the side, thanks for joining. And I think the three other speakers, thanks as well.
Justin, thank you so much. Solly?
It is key that we should actually confront stigma and ensure that access to treatment, care is appropriate, and people with epilepsy are given an opportunity to live, productive lives and contribute to society where they can. Understanding that, it is a very complicated condition that in some instances it can be disabling, but more of the people with treatment and proper care, they can be able to lead fulfilling lives, as we have seen here.
Great, thank you, Solly. And Pandile, last question, just closing remark, and just closing remark from your side.
Okay, thank you, Charlene. People just need to remember that there are different seizure types, and I hope people also stop requesting EEGs when it's unnecessary. And what I've gathered from Solly and Justine is that I actually need to engage my patients as well when it comes to doing my epilepsy clinic, because most of the time it's a question of, seizures control, when was the last one? Okay, treatment's fine. But the psychosocial aspect of things, I don't think it's properly addressed. And that's the only way we'll know how they feel and what the stigmas are, and then we'll refer them to the right people. Thank you.
I think what you've also said, I'm going to wrap up in my final comments, is that we'll be in touch with you as Epilepsy South Africa. We've got seizure diaries that we built. We've got resource tools that we can actually make available to the clinic so that you can make it freely available to your patients. So thank you for bringing that as a bridge between civil society, as us as a civil society organization, focusing on epilepsy, and your side. It's really wonderful to hear that shout out. From my side, just thank you for joining us today. Thank you to our three panelists for the amazing information. And remember, you can join us as a member. Go onto our website, there's membership forms, join us. We'll give you access on a monthly basis. It'll be a push from us to you. Beautiful information to support you. So it's not just a once off and you'll get it as a reminder. And on behalf of Epilepsy South Africa, our branches around the country, thank you for being a part of our journey and enabling us to educate and share valuable information with you. What I've also taken the liberty of doing while our panelists have been closing is just screenshotting all your questions. So we will, to help you, is type those out on our support page as well and be answering them there as well. So once again, have a very, very blessed day and rest of your week and a superb weekend. Yes, it's around the corner. And from me, take care and have a wonderful day. Thanks, everybody.
Thank you.
Thanks, Justin. Thanks, Pandile.